بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم.
Bismillah ar-Rahman ar-Rahim. I will discuss with you now the lecture of resective osseous surgery. First, we have to know the definition of osseous surgery. It is defined as the procedure designed for removal of alveolar bone deformities induced by the periodontal diseases or other related factors such as exostosis and tooth supra-eruption. As we mentioned in the first part of the lecture of bone loss and how bone loss causes bone deformities. So, it is done to create a physiologic contour which mimic the final gingival architecture. You know that the gingiva always mimic the underlying alveolar bone. First, we have to know that the first objective of osseous resective surgery is the elimination of periodontal pockets and the creation of shallow gingival sulcus that can be readily maintained by the patient and the dental professional. This is the primary goal of osseous resective surgery. So, osseous surgery can be either additive or subtractive in nature. What is the meaning of additive? Additive osseous surgery includes procedures directed for restoring the alveolar bone to its original level. It is not to its original level, it is almost nearly to its original level. And this is done by the bone grafting techniques. Whereas subtractive osseous surgery is designed to restore the form of the pre-existing alveolar bone to the level existing at the time of surgery or slightly more apical to this level. Now, how to select the treatment technique? The morphology of the osseous defect largely determines the treatment technique to be used. For example, one wall angular defect usually have to be recontoured surgically with osteotomy, as I will mention, I will discuss with you in the next figures. While three-wall defects, particularly if they are narrow and deep, can be successfully treated with techniques that aim at new attachment and bone regeneration with bone grafting techniques and membrane. While two-wall angular defects can be treated with either method, depending on their depth, width, and general configuration. Of course, when these two-wall angular defects are deep and narrow, it is good for excellent for bone grafting techniques for bone regeneration, while wide and shallow two-wall defects along with the interdental craters osseous defects are treated with the objective of obtaining optimal repair by natural healing processes. Now you have to know the characteristics of the normal bony form of the alveolar bone, the normal form of the alveolar bone. Number one, the interproximal bone is more coronal in position than the labial or the lingual or palatal bone and the pyramidal in form. You know that. But the form of the interdental bone depends on the tooth form and the embrasure width. So the more tapered the tooth, the more pyramidal is the bony form, while the wider the embrasures, the more flattened is the interdental bone mesiodistally and baccolingually. Also, the position of the bony margins have to mimic the contour of the septentrional junction. As you see, this is a normal configuration. The bony margins mimic the contour of the CEG. So the distance from the facial bony margin of the tooth to the interproximal bony crest is more flatter in the posterior areas than the anterior. Here I want you to know that the bone, the alveolar bone covering the roots is named or termed the radicular bone, while the bone between the roots is termed interradicular bone. Okay? So, teeth with prominent roots or that are displaced to the facial or lingual may have fenestrations or dehiscence. Okay? The molar teeth have less scalloping and a more flat profile than the bicuspid and incisors. Because of that, the interproximal bony crest is more flatter in the posterior areas. See here in the right slide, there is a fenestration, bone fenestration. There is a window. Fenestration means a window. There is a window in the bone. When this window of fenestration extends to the marginal bone, labially, as you see, or facially, this is called dehiscence, as you see in the first premolar. This is the second premolar, this fenestration, while in the first premolar there is a dehiscence where fenestration extends to the marginal bone. What about the terms to describe the bone form after you make your reshaping or you make your resective surgery? We may achieve either a positive architecture, flat architecture, negative architecture, or a negative architecture. Okay, leave the ideal form now. The ideal form, okay, now we begin with the ideal form as we mentioned, where when the bone is consistently more coronal on the interproximal surface than on the facial and the lingual surface. This is a normal. Now, what the term describe after your reshaping? May positive architecture, in this case, said to be positive, the architecture said to be positive if the radicular bone is apical to the interdental bone. While negative architecture, as in C, the interdental bone is more apical than the radicular bone. This is the reverse of the positive architecture, which you see in A. A and C. This is the reverse of each other. While flat architecture is the reduction of the interdental bone to the same height as the radicular bone. Okay, when you do, of course, when you do your reshaping, your goal is to achieve the positive architecture because it is near to the ideal form. Now, what are the indications of osteoplasty? Number one, pocket elimination, because we mentioned that the goal of the osseous resective surgery is the elimination of the periodontal pockets. Number two, tori reduction. Three, intrabony defects adjacent to edentulous ridges or incipient furcation involvement. Number five, reduction of thick heavy ledges or exostosis. Shallow osseous craters or blunt interdental craters, or small intra-bony defects associated with the buccal or lingual surfaces. So you have to study these 8 items very well. Indication of osteoplasty. So osteoplasty includes 2 steps, and I will show you this in the following diagrams. First step is the vertical grooving or festoning. Second step is the radicular blending. Now, what about the indications of osteotomy? Indications of osteotomy: sufficient bone remaining for establishing physiologic contours without attachment compromise. Number 2, no aesthetic or anatomic limitations to do osteotomy. Number 3, elimination of interdental craters. Deep interdental craters. Number 4, intra-bony defects not amenable to regeneration. Number 5, horizontal bone loss with irregular marginal bone height. Number 6, moderate to advanced furcation involvement. And number 7, hemiseptal defect, which is a one-wall defect. The contraindication of osteotomy is areas of sufficient remaining attachment, or where osteotomy or osteotomy might unfavorably alter the prognosis of the adjacent teeth. So it is, in this situation, it is contraindicated. Or in anatomic limitations, prominent external oblique ridge or zygomatic arch, etc. Or this you can't do osteotomy. Or aesthetic limitations, high smile line, or when you do it anteriorly, these all contraindicated for osteotomy. Or if there is an effective alternative treatment. Alternative effective treatment as bone regeneration or other treatment which is alternative to osteotomy. Before you do your osseous resective surgery, first of all, as you know, you have to do a comprehensive periodontal examination to identify the potential for the use of osseous resective surgery. This implies or requires the following. First one, the clinical examination, as you do in the clinic, your clinical examination, the pocket depth, attachment level, the location of the base of the pocket related to the mucogingival junction, and attachment level of the adjacent and attachment level of adjacent teeth, the presence of furcation defects, and the bone topography. The bone topography. How we will do to know the bone topography. See here, when you make a vertical insertion of the probe in the left figure, this may not detect the interdental crater. There is an interdental crater here. So vertical insertion of the probe may not detect the crater, but when you make the probe in oblique position, so this will reach the depth of the crater, and this will help you to know has an information about the bone topography interdentally. So bone topography of intra-bony pockets intra-bony pockets and furcation defects can be predicted by the use of what we say transgingival probing or the sounding technique. So why we do sounding technique or the transgingival probing, why it is useful? Because the information obtained about the bone topography can change completely the treatment plan and your flap design. For example, when you have an area with a narrow defect that was unnoticed in the initial probing, and radiographic assessment is ideal for and radiographic assessment you cannot notice it in your initial probing or in the radiographic assessment, so it is ideal for augmentation procedure. So this requires a change of your flap design and the osseous procedure. So if you miss to detect the bone topography of the area, you will we will not change your treatment plan or your flap design, and there will be a failure. So what is the transgingival probing or the sounding technique? It is a very painful procedure, so anesthetize the tissue before inserting the probe. The probe should be walked along the tissue-tooth interface so that the operator can feel the bone topography. The probe may also be passed horizontally through the tissues, through the gingiva, to provide the three-dimensional information regarding the bony contours. What are the three-dimensional information? The thickness, the height, and the shape of the underlying base of the defect. So this gives you a good information about the bone topography of the defect. The transgingival probing has to be done just before the surgery. Just before the surgery. You have to make it just before the surgical technique. Then what about the radiographic examination? Radiographs does not show the number of bony walls of the defect, nor the presence or and extent of the facial or lingual bone defect because of the opacity of the roots. So it's obscured by the opacity of the roots. So as I mentioned to you in the first lecture of bone loss, that radiographs cannot give you information about how many walls the defect. Therefore, both radiographic and clinical examination are necessary to indicate the presence of the interbony defect. Now, what are the osseous resection techniques? Number one, we have 4 steps. Number 1, vertical grooving. Number 2, radicular blending. These 2 steps are purely osteoplasty steps. Number 1, the vertical grooving. Vertical grooving, I will show you how it is done in the diagram, in the following diagram. It is the first step designed to reduce the thickness of the alveolar housing and to provide relative prominence of the radicular aspects of the teeth. And it also provides continuity from the interproximal surface into the radicular surface. When we do vertical grooving, in case of thick bony margins, shallow craters formation, or other areas that require maximal osteoplasty and minimal ostectomy. The contraindication of vertical grooving is in teeth with close proximity, areas where the teeth with the roots are in close proximity, or thin alveolar bone housing. Here in the diagram, we will I will see this case. In A, there is thickening of the or bulging of the alveolar bone, but raising here bone formation. With what? With shallow crater, shallow interdental crater. So what we will do, The first step is the vertical grooving. Where we do vertical grooving, we make vertical grooving with a round pair carbide or diamond pair with low speed contra. So we make this vertical grooving in the interradicular areas. In the interradicular areas. This is the vertical grooving. Okay, we notice here that it also treats the shallow crater, and we mentioned the indication of osteoplasty is the shallow or blunted crater. This is shallow interdented crater. Okay. Then the second step after vertical grooving is the radicular blending. The radicular blending is done by sweeping strokes to achieve or establish an even flowing thin radicular surface. So this second step, it means extension of vertical grooving in an attempt to gradualize the bone over the entire radicular surface to provide the best results from the vertical grooving. This provides a smooth blended surface for good flap adaptation, and its indication are the same as in vertical grooving. So both vertical grooving and radicular blending are purely, as I mentioned, purely osteoplastic techniques. There is no removal of the alveolar bone support. This means shallow crater formation, thick osseous ledges of bone on the radicular surface in class 1 and early class 2 forcation involvements. Those are treated almostly with these two steps, vertical grooving and radicular. As we see here in this diagram, this is in A, this is original lesion with thickening or bulging of the facial bone and shallow interdental crater. After we did the vertical grooving, this is the radicular blending. See here, I see here how we gradualize the bone over the prominence of the roots. This is the radicular blending, and it is done, as I said to you, by sweeping strokes to achieve the even flowing thin radicular surface over the prominence of the roots. But now we can't let this shelf-like marginal bone like this, and we will see this will be corrected by the Ustectomy technique. Then the other surgical or resective surgical technique is the Ustectomy technique or Osteotomy technique. It is done by two steps. Number one, flattening of the interproximal bone. It is a pure osteotomy technique. Number two, marginal gradualization of the bone. So flattening of the interproximal bone requires the removal of very small amount of the supporting bone. So it is indicated when interproximal bone levels vary horizontally, and it is indicated in one-wall interproximal defects or the so-called hemiseptal defects. It is also used in case of a combined defect, where one wall edge of a three-walled angular defect is found, and it can be helpful in obtaining good flap closure and improving the healing of the three-wall defect. So this is a combined defect where the number of walls apically are more than coronally. But what is the limitation of this step? It is limited in the treatment of advanced lesions as large hemiseptal defects, which will require removal of incoordinate amounts of bone to provide a flattened architecture. So this is contraindicated in this. This technique is contraindicated in this case. See here, this is the flattening of the interproximal bone. You see the discrepancy between the level of the bone lingually and facially. So we make what? We make flattening of this interproximal bone and take care to protect the focal bone, not to bear deforcation, not to make a pathological situation in these teeth. The facial crest height is reduced in both the interproximal areas to the depth of the defect. This is flattening of the interproximal bone. It's the gradualizing the marginal bone. It is an osteotomy process. Bone removal is minimal, but it is necessary to provide a sound regular base for the gingival tissue to follow. You know that the gingival tissue follow the underlying bone or maybe the underlying bone. So we can see this in this diagram here and the following one. This is again, this is the original lesion, shallow crater and heavy bone ledge or thickening or buttressing conformation. In B, we did vertical grooving, where in the interradicular bone grooving, vertical grooving. Then in C, we make what? Gradualizing of the radicular blending. Radicular blending to make the even flowing thin radicular surface. This is in C, the radicular blending. So here we can't leave, as I mentioned to you, this shelf-like marginal bone. Okay, so we make here gradualization of the marginal bone. Gradualization of the marginal bone over the roots, like we achieve this result in D. This is the end result without bearing of the forcation or without excessive removal of bone of the marginal bone. This is a healthy situation in D, where you see the interproximal bone is more coronal than the marginal bone or the facial bone or the lingual bone. In this here, see here also in A, this is not as the previous lesion. This is thickness or buttressing bone formation or bulging of bone, and with blunted interdental area. This is blunted interdental area. It is not a shallow crater, it is a blunted interdental area. Then in B, we made what? We did vertical grooving with the round burr, where in the interradicular area. Okay. In C, we make what? With the this round burr, we make gradualizing. We make radicular blending. We make radicular blending to achieve or establish an even flowing thin radicular surface. In T, what do? We may remove this shall the first in B and C, this is purely osteoplasty technique, okay, which is vertical grooving, I repeat again, and the radicular blending. But in D, we make here Ustectomy technique. We remove a little bit some of the alveolar bone support from the marginal bone. We can't leave it as a shelf-like configuration, so we scribe the bone or outline the bone to be removed, and with a chisel we remove this bone. And in figure F, this is the complete reshaping technique. Note that a thin bone with ideal interproximal contour. Although in F, the bone is lower level than in A in the original, but this is a healthy situation. This is an ideal situation. This is a positive architecture. Okay? Then here, this is another situation which describes the Ustectomy technique, the flattening of the interproximal bone and the marginal gradualization of the bone. These two steps of Ustectomy. In A, there is a deep interdental crater. Okay, how we deal with this or manage this case? So as you see in B, we remove the we make flattening of the interproximal bone. We remove the buccal and the lingual portion of the crater. So this is a flattening of the interproximal bone, or you can say it is a horizontal grooving, not a vertical. It is a horizontal grooving. So with a small round burr, it is used to reduce the buccal and lingual crater walls. See, in C, here we can't leave like that. So we have to gradualize the marginal bone. To gradualize. In C, you create a negative architecture where the base of the interdental bone is in a apical level than the facial or lingual bone or the radicular bone, and this is not good. So we have to scribe the bone to be removed, as you see in C, the dotted line. Then remove the bone with a chisel. In G, bone removal is removed with a chisel. When we do that, see or note these bone spicules, small bone spicules interproximally. This residual bone are named widow peaks. Widow peaks. Bone alone. Bone stands alone. You know that if we adapted the flap to this configuration, the gingiva will seek to the highest level of bone. To the highest level of bone. Okay? So it will recede quickly after a while, after the surgery or after during healing, because these are weak points. So we have to remove these widow peaks. In E, as you see, removal of residual bone or the widow peaks at the line angles and interproximally. Then, as you see in F, osteotomy was completed and the physiologic form is established, as you see. So compare between A and F. See your resective osseous osteotomy technique make a good end result, or an excellent and healthy end result. This is also a correction of the interproximal deep crater. See, this is a deep crater. In A dash, this is the form of the deep interdental crater, and in A dash, this is the ideal correction. We remove the buccal and lingual bone of the crater. In B, this is also another way to treat the deep interproximal crater, where we remove only one edge of the crater, which is the lingual part. Okay, and this is in B dash when we remove the lingual part of the crater or lingual bone. See in C, this is another shape of a crater where it is tilted, the crater tilted lingually, and we remove only the lingual bone of the crater. Okay, see here, this is another figure to understand this step. The shaded areas illustrate different techniques for the management of such defects. But here in the first one in the left, from the left to the right, in the left one, in the middle one, and in the third one, the technique that reduces the least amount of supporting bone is preferable. Why? To not make the tooth to be compromised tooth. Okay, so this is the management of deep craters. So the bone is either ramped buccally or lingually, with only one of the walls totally removed, while the other is only partially reduced. Okay, so here in the middle and right figures, sometimes the defect, as you see, is positioned either buccally or lingually, favoring removal of only one wall and therefore ramping the bone in that direction. Okay. In this figure also, this is showed to you bone ramping of the crater from one in one direction. It is usually preferred to ramp the buccal margin, as you see. Then in the other figure, in the lower one, this is a deformity of the marginal bone. In B, the removal of the pre-marginal bone and lowering of the level of the bone. This is a marginal gradualization of bone to make the interproximal bone in a more higher level than the radicular bone, yes, to achieve the positive architecture. See here, this is a treatment of one wall angular defect related to edentulous area. In A, this is an angular bone defect mesial to the tilted molar, and in B, there is bone ramping of the this wall. Ramping means sloping. So we make sloping or bone ramping, so the defect is reduced by this technique. This is an osteotomy or ostectomy technique. Thank you very much and best wishes for you.